Hello, and welcome to today's episode of Obesity in Canada. Joining me today is my colleague and dear friend, Dr. Akshay Jain. Dr. Jain is an obesity specialist out of British Columbia. He is incredibly humble, so I do need to take a couple of minutes just to give him a few props. Dr. Jain is triple board certified by the American Boards of Endocrinology, Internal Medicine, and Obesity Medicine. He holds a number of other clinical certifications, and he has a whole host of research interests, including diabetes, thyroid disorders, adrenal dysfunction, obesity, and more. Currently, he is the president of the Canadian chapter of the American Association of Clinical Endocrinologists. Welcome, Akshay, and thank you so much for joining me today.
Thank you so much for having me, Dr. Walji, and it's a pleasure to be on your wonderful podcast.
So actually today we're going to be talking a little bit about changing the conversation around obesity. This is a really important topic because the conversations that we have with our patients can really set the tone for treatment, right? We have this long history of healthcare providers encouraging our patients to, eat better, eat healthfully, to exercise more in this effort to prevent and treat obesity. But more and more, experts like us in the field are saying, wait a minute, that's maybe not the right message that we should be sending out to our patients. What are your thoughts on this message of, eating better and exercising more to treat obesity? What are the risks of that sort of messaging?
I think that's a really important question to start off with. For the most part, healthcare providers, unfortunately, still do not understand the complexity of obesity. We have been misled to believe that obesity is just a condition of overnutrition that primarily stems from the patient's inability to control their eating habits. And it basically denotes that the individual is a very sedentary person, so is not expending that energy. But it's really important to understand that obesity is a very complex condition. And by just giving this gospel to patients that, hey, eat less and move more, we are actually oversimplifying obesity and putting too much focus on that weight, that number on the scale. So really what we need to do is take a step back and look at obesity, deconstruct it, and then start building up piece by piece. And then we'll be able to do a better job at managing and counseling patients. So it's really important to not just focus on this, very archaic message of eat less, do more, but deconstruct obesity and start working from ground level again.
Oh, for sure. I would have to agree because, when we do simplify obesity like that, make it really a willpower issue, our patients feel bad and it can be really damaging to that therapeutic relationship. So, we know that research has shown that there's, educational programs aimed at shifting healthcare provider attitudes and beliefs about the complex causes of obesity that can translate into less blaming of the individual. So you use this word deconstruct. I love that word. I'm going to take it and I'm going to use it with my other colleagues, and I'm going to use it with my patients too. Let's deconstruct obesity. If we were to deconstruct obesity, what are the kinds of things that we should be talking about with our peers?
I think the first and most important thing to understand is figuring out the normal physiology of the body and understanding that as human beings, our caveman-like wiring in the brain is to always ensure that we are preserving nutrition. When an individual suffering from obesity starts losing weight, the body will naturally try to apply brakes on that. And there will be a point of time when the individual will hit a plateau and not be able to lose weight. And at the same time, what's happening is the body doesn't understand why we are losing weight. And at a very basic level, it will start increasing cravings for food. It will try to regain what we have lost. It's important to understand for healthcare providers that there will be multiple times in an individual's journey with managing their obesity where they will be hitting a plateau. And unfortunately, there can be weight gain. And this is where we really need to make sure that our patients have all the tools in their armamentarium to be able to deal with that. They need to first have realistic goals as to what degree of weight loss they can expect. Studies have shown that most patients, when they go to their doctors and obesity management center, their expectation of weight loss is about 3 to 4 times more than what is realistically achieved. So it's really important to set that background, because otherwise we are setting us and our patients up for disappointment. Patients, if they do not lose the weight loss that they are expecting, then they'll feel that all those efforts were of no use. Understanding that there will be pitfalls along the journey is also very crucial. And then most importantly, it's important to note that just that eat less, do more gospel doesn't work. We got to make sure that the patients are well equipped. Sometimes that could involve behavioral management. It could involve pharmacological treatment, and it can even involve surgical techniques.
Oh, for sure. And so I would have to agree with you 100%. Just understanding the science of obesity, understanding the basic science of eating behavior, energy intake, energy expenditure really helps to set a good platform to then understand what's happening in obesity. And I think once healthcare providers understand that better, they can convey that information to patients, and it really helps to manage expectations. I liked how you were talking about the body's biological defense mechanisms against weight loss. Sometimes when I'm talking to patients, I compare it to how the body defends against other changes, like a change in body temperature, right? So if your body temperature drops, you shiver, so the body's just so well designed to defend against any change. And I think when we all, as healthcare providers, start thinking about obesity that way as well, it will really help change the messaging that we convey to our patients, and it will help have these conversations about weight loss expectations with our patients. Now, you mentioned pharmacotherapy, and that's where things are kind of really exciting, I think, in the obesity landscape right now, because now we have these new medications that are actually working in the brain regions that are involved in energy intake. Do you think that having these tools available are going to help us, as a group of healthcare providers, move management more beyond that eat less, move more type of approach?
Oh, absolutely. I feel that it's such an exciting time as a healthcare provider to be able to care for patients struggling with obesity, because we now have such effective tools that we can utilize that will further augment the patient's efforts. As you mentioned, Shai, that when we look at pharmacotherapy, we got to make sure that it is working in ways where the patient gets that further boost when they are trying to optimize their lifestyle change. And coming back to the physiology, we know that, the brain can apply brakes. So there's medications now which will work on those particular centers of the brain, whether it is the reward center of the brain, where we perceive food as more of a hedonistic pleasure, or if we look at that center of the brain where we figure out how satiety works or how hunger as an underlying feeling works, these medications are now able to work on these specific centers of the brain. And the results are remarkable, where originally it was stated that a medication that can cause 5% of weight loss is good enough. Now we have medications that can even get up to 17% weight loss, which frankly is something that I would have never expected, years ago. So it's really reassuring.
Oh, for sure. And it's kind of neat, because more and more we're approaching obesity based on the principles of chronic disease management, which is really what we should be doing, right? Kind of like what we do with treating hypertension or treating diabetes. It's multimodal, it's long-term treatment, it's the use of these pharmacological tools that are actually working on the pathophysiology of these chronic diseases. And the results, I agree, that we're seeing with the newer medications are exciting. Now, getting physicians to think about and treat obesity as a chronic disease is one thing. Getting a patient on board is another thing, because our patients have been hearing this narrative: eat less, move more, have more willpower their entire lives. And so this is how they understand weight. This is how they understand weight loss. So I kind of feel like it falls on us to shift our patients' thinking, right, about obesity, about weight and weight management. But this is such a sensitive topic.
Thank you so much for bringing up that point, Shai. I think really as healthcare providers, we need to foster a very non-judgmental environment. It's important to understand that individuals who are living with obesity have been struggling with this 24/7, not just from the physical aspect or mental aspect, but even as a society, we put so much emphasis on body shape, on how someone is supposed to look. And it's important to note that this individual living with obesity has been facing that stigma from people around them, even from healthcare providers. Studies show that individuals living with obesity are often hesitant to bring up discussion about obesity because they feel that their healthcare provider may not be open or be able to have a good discussion with them. So they often wait for a long time. And sometimes even when they bring it up, the healthcare providers have not been able to give a non-judgmental approach. So I think it's important that we first bring up that topic and ask for a permission from the patient and see if they're open to discussing this. And if not, we can always tell them that if there's ever a point of time when you want to talk about obesity, we can talk about how this disease, and it's important to classify this as a disease, how this disease can be managed just like your hypertension, just like your diabetes, just like any other condition. So I'm here for you.
Oh, totally. I find that even little things like just making sure you have all sizes blood pressure cuffs in your rooms, making sure that the reading material in the office is kind of weight neutral, using the right language, just little things that we pay attention to really, I think, can help our patients feel.
Yeah. Making sure that the chairs in the waiting room are accommodating. The weighing scale that you're using has support so that, individuals living with obesity have significant osteoarthritis. If there's a high step up, they might not be able to get up on that scale.
Totally.
And making sure the scales do have that range that can gather all information.
Yeah, for sure. And sort of situating that scale in a private area. So, little things like that, just attention to those little details, I think can really help patients feel like more comfortable, right?
Mm-hmm.
We have our patient in front of us. We've had this conversation about weight. We've sort of explained to them what's happening in their bodies and the body's defenses against weight. When it comes to discussing treatment options, things are a little bit different than they used to be. We used to do kind of a stepwise, try lifestyle first, then medications, and then bariatric surgery. But things are different now, isn't it?
Yeah, absolutely. So when I talk to patients, I tell them that your weight is in a range that meets the criteria for managing with pharmacotherapy. Is that something that you're open to discussing today? And a lot of times individuals may not know that there's medications available for weight loss. And it's also important to discuss that. So the criteria for using pharmacotherapy is if an individual has a BMI of 27 or higher with comorbidities or a BMI of 30 or higher, then they do meet the criteria for initiation of pharmacotherapy as an adjunct to the efforts that they're already putting in for lifestyle.
Yeah. So really, we're looking at the patient in front of us. Do they meet the criteria for this intervention? And then we just sort of offer it to them upfront and explain to them that we can do two things at once. It doesn't have to be step 1, step 2, step 3, right? I don't know. Do you have a couple of key takeaways that you wanted to share with our listeners today?
Absolutely. So I'd like to talk about 3 things as my final pulse. The first thing is please be open about starting that conversation with patients about obesity and have a very non-judgmental approach. That becomes really, really crucial. The second thing that I wanted to talk about is obesity management is very complex. It's not just a simple preaching line of eat less, do more. There's many more layers that go around there. And the third thing is, as you mentioned, Shai, we don't really have to go in a stepwise manner when we manage obesity. We can start several things at the same time. So using pharmacotherapy along with as an adjunct to lifestyle modification is very crucial.
Mm-hmm. I agree with all of those points. And I think even practicing how we convey those messages to our patients, practice with your family, practice with your friends, and then take that and practice all of those 3 key points with your patients can be just so helpful. And it can be really nurturing to that therapeutic relationship, right? Actually, thank you so much for joining us today. And I just want to quickly thank all of our listeners. Until next time.
Thanks for having me, Shay. Bye-bye.
Bye.
The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MD Briefcase or Novo Nordisk. This podcast does not constitute medical advice and is only meant to educate and inform the listener. This podcast is available at mdbriefcase.com and has been developed by MD Briefcase and supported by educational funding from Novo Nordisk.